The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Well, thanks for giving me the opportunity to talk about sepsis. Clearly, this is a very major and important aspect of what we do with medical emergency teams and medicine in general. And so, how do we recognize that our patients have sepsis? Well, there is a problem, and recognizing sepsis is not like recognizing a chair. We all know what that is. With sepsis, it's complicated because it's actually a concept. It's a man-made construct. It's not an object. It's a syndrome that we characterize and we use shorthand to describe, but there isn't a gold standard to diagnose that it's there. So we have to create definitions in order to operationalize the way we deal with it, the way we communicate, and the way we discuss it, and hopefully the way we identify it for epidemiological purposes and treat it. Now, this was clearly a need that was obvious to people way back. And the first definition, as you might be aware, was in 1991. It was followed by a second definition by a task force in 2001. Now, these definitions required some specific criteria which became popular or, depending on the perspective, non-popular or problematic, particularly the so-called SIRS criteria, the Systemic Inflammatory Response Syndrome criteria. It included concepts like severe sepsis on top of sepsis and had characteristics that led to problems. In particular, a lot of literature accumulated since then that the SIRS criteria have limited sensitivity in identifying people that by any other sensible, commonsensical criteria actually do have sepsis because they are in ICU, they've got an infection, they go on to die. And also had limited specificity because the SIRS criteria are present in other inflammatory states like cardiac surgery, bleeding, reperfusion injury, and so on and so forth that are not specific to sepsis itself. So then there was a concept of severe sepsis, and for many people this was a little bit confusing. Well, there are many people argued there either is sepsis or there isn't. Severe sepsis seems like an unnecessary additional sort of construct. And this is kind of important for epidemiologic purposes, for funding, for understanding of outcomes, for interventions and so on, because depending on the criteria that you use, you have very different outcomes. So the incidence of sepsis in the United States in hospitals moves from 900,000 to 3 million. And the mortality varies significantly across all these different definitions. So that's, again, seen to be an epidemiologic and funding and research problem. And, of course, with these different criteria in different studies, you have dramatically different outcomes that make it difficult for people to compare performances and move forward on a global scale. So, in order to continue to work on this agenda and hopefully provide more impetus to improve what we do and the way we talk about it, the European and American Society of Critical Care Medicine decided to create a task force to help define sepsis. Unfortunately, this was made up of stupid people like me that are white, old, flabby, Anglo-Saxonoid. I'm Italian, so that's all right. But and there were, no people from developing countries. There was no female in this group, and it was a kind of problematic, very sexist group of, it was all bad. Nonetheless, all these bad people got together and tried to come up with and tried to make some moves in the right direction. And whether they have or they haven't, time will judge. But this culminated in the publication of Sepsis 3, because this is the third time that the task forces tried to address the definition. And Sepsis 3 was published in JAMA last year. And it contained a variety of aspects that are worthy of discussion. So this is how these old, flabby, graying people of Caucasian descent thought about it. First of all, you have to have infection. If you don't have infection, it's difficult to argue that you've got sepsis. But we were in the business of defining what infection is, because that's really difficult. And we said, well, sepsis is not just having infection with these strange inflammatory response criteria, because we now know from biology and research that the host response is really fundamental. And so a more simple construct is that sepsis is really bad infection. And then you have to say, what is bad? You know, if you have a common cold and you're feeling woozy, if you have man flu and you're at home lying in bed for 3 days feeling miserable and having your wife saying that you're a wimp, is that sepsis? And we decided, no, that doesn't count. You have to have more than that. You have to have organ dysfunction. We decided that that was the defining characteristic of sepsis. You had to have infection and you had to have organ dysfunction. And the concept of severe sepsis seemed unnecessary. So sepsis is a situation where you've got infection and there is a life-threatening organ dysfunction which is caused by, at least in part, together with the infection itself, by a dysregulated host response to infection. So sepsis is what people used to call severe sepsis, and we've removed anything before that. And we emphasize the host response because we have a lot of data, biological and physiological, that if you have an infection and you have a regulated host response, that's man flu. You have the infection, you have the virus, you have a fever, you have tachycardia, you've got a bit of tachypnea, you feel terrible, your wife's yelling at you, and then you slowly make it better because the immune system is responding to it correctly or appropriately or effectively. But if you have, for example, man flu and it progresses to ARDS, then it's a completely different story. Now you've come into sepsis. You've got a dysregulated response to infection. There was another concept that we had to tackle, which is the concept of septic shock. That's a little bit more problematic. And we asked ourselves, is septic shock simply sepsis where the organ dysfunction is in the cardiovascular system? And we said, no, this isn't really what septic shock is. Septic shock is a different level of severity, possibly a different level of pathobiology, but at this time we don't fully understand it. So it's not just having a low blood pressure, it's not just having cardiovascular dysfunction and having the cardiovascular organ failure as the element of sepsis. It is more than that. If it is more than that, what is it that can divide septic shock as a subgroup of sepsis or a separate component of sepsis? Well, the answer is mortality. And then that we felt that septic shock is really bad sepsis. It's a subset of sepsis where there is circulatory, cellular, and metabolic dysfunction, which is associated with a greater risk of mortality than sepsis itself alone. So when we came to creating definitions, we tried to include information of what we now understand about the physiology of sepsis. We're trying to involve a concept surrounding the pathobiology and the immune response. But having said all of that, having said about organ dysfunction, having said about infection, having made statements, there are issues about how do you turn it into something that people can understand and use at the bedside, and that has a degree of validity. So if you're going to move from all those high-level conceptual definitions, a bit like a mission statement or a vision statement, to operationalizing the stuff so that clinicians, nurses, physios, doctors at the bedside can have something that they can use, you need to operationalize all of these ideas. So you need to have something that is preferably data-driven and that can use clinical criteria and clinical measurements that are commonly used, because if you ask people to measure adrenal medullin in the blood, then it is not useful to have such a definition. And so we produced some information based on large databases that would allow us to understand how to operationalize this condition. Now, we were able to leverage a very large database of more than 1 million people admitted to the University of Pittsburgh Medical Center with Chris Seamer, and to identify about 148,000 people with suspected infection. And we were able to then divide them into a derivation cohort and a validation cohort. So from there, we were then able to move to other large databases to validate or support what we were finding in the University of Pittsburgh Medical Center. So we went to the Kaiser Permanente database, to the VA database, and you can see there we're dealing with millions of people where we had information about several characteristics, including the possibility of infection. So we used these electronic health records, and we tried to determine the first episode of cultures and antibiotic therapy to determine when infection was first suspected, and then when the criteria could be applied at the time when the clinicians were seeing the patient for the first time, and so that we were able to look at an interval or an area when this evaluation would be taking place, and we would be able to assess what criteria were present or useful at that time that would allow us to define that there was organ dysfunction, and that would allow us to go further and define whether such organ dysfunction was actually able to predict mortality or prolonged time in ICU. And we looked at these 3 groups of criteria: the sequential organ failure score, the logistic organ dysfunction score, and the OSIRS, to try and understand if they had different utility in separating patients in what we really thought sepsis would be. So there is the infected patient and there is the septic patient, and in simple terms, there is somebody who's really sick. But of course, that's a proxy, and now we need to understand how to define it in reality. In order to define it electronically and to validate definitions that can be validated electronically as leading to what really sick is, then we had 2 outcomes: death and prolonged stay in ICU as proxies that whatever criteria we would use would help define people that were really, really sick. So we looked at a primary cohort of 148,000 people located in various parts of the hospital. We looked at the distribution of the existing criteria, and we noted, first of all, that these criteria, in the end, even if they are relatively simple, they still carry some complexity, because a lot of them require laboratory tests. And it's not immediately available to all patients, certainly not in developing countries, but also sometimes in developed world countries. So we also tried to assess criteria that were available at the bedside that were simpler, and we studied 21 variables that would be available at the bedside to develop a potential system that would allow you to identify at the bedside whether the patient was really sick or was likely to become really sick in the setting of infection. And we developed a concept called Q-SOFA, quick SOFA. SOFA is sequential organ failure assessment. And that was based on the respiratory rate, the patient's state of confusion or altermentation, and the presence of hypotension. These are things that you can see at the patient's bedside anywhere in the world. And we assess these criteria for the ability to predict outcomes in the ICU environment. As you can see there, in the ICU environment, organ dysfunction, as marked by the SOFA score and the logistic organ dysfunction score, are clearly much better than the Q-SOFA and the SIRS criteria in identifying people that are sick. But of course, this is in the ICU. But outside the ICU, this is a different kettle of fish, because in the ICU, you've already modified everything. Outside the ICU, both the SOFA, the logistic dysfunction score, but also the quick SOFA are better than SIRS and equivalent. So the quick SOFA becomes a potentially useful technique for identifying patients at the bedside with 3 simple variables that might help you identify who's going to be more likely to die, who's going to be more likely to stay in ICU for a long time, and therefore kind of identify patients that have sepsis and are at the risk of unfavorable outcomes. And then we validated that in large databases, coming up with very similar characteristics and a predictive value around 0.7 to 0.8. Then we did all sorts of sensitivity analysis, changing the time window around the infection, changing the Glasgow Coma scale of assessment of altered mentation. We did all sorts of sensitivity analysis with imputation of data, and we found that there was some significant robustness around these variables. And then, of course, knowing the SOFA score in a particular moment in time has its problem, because you really want to identify that there has been a change. And we looked at the changes in SOFA score with these large databases, and we were able to identify that there was greater predictive ability by looking at 2-point change in SOFA score. Then we moved on to septic shock, another challenge. And we identified, or we emphasized, the circulatory and cellular abnormalities were an important component of shock, not just hypotension. We used the Surviving Sepsis Campaign database, and we also had a validation cohort from Kaiser Permanente and from Pennsylvania to assess whether these variables were indeed predictive of outcome. And this is to emphasize why we argued that hypotension and circulatory dysfunction is not enough to diagnose septic shock, and the lactate is an important variable as a marker of metabolic and physiologic stress, because people that have a lactate above 2, whether it is in isolation in the setting of sepsis or in the presence of circulatory dysfunction, have a much greater mortality. So septic shock then is defined as a subset of sepsis with circulatory and cellular abnormalities or metabolic abnormalities that increase the risk of mortality compared to sepsis alone. So hypotension in of itself is not enough. There has to be evidence of metabolic physiological stress. So this is what we did, and now there is a consensus definition. It's been out there for a bit more than a year. The article was published. It was hit by 2 million people around the world. It's obviously had great resonance, and it provides an operationalized set of criteria by which you can operate within consensus with the rest of the world and have a uniform definition that you can apply to recognize sepsis. So when you go to the patient's bedside, the language will be, the patient has infection. Your mind says, does this person have sepsis? Is this person at greater risk of having an unfavorable outcome with greater mortality and greater or prolonged ICU stay? Well, you have to do two things. You have to see if there was a change in SOFA score, and you have to see if they got a quick SOFA, which is positive for being at higher risk. That's what the definition says. And then the next question is, does this person have septic shock? Could this person have septic shock? Then you look at the circulatory status of the patient and you measure in lactate. This is in the developed world. That's the process of assessment of somebody that you've been called to see in the hospital who's got infection, and in our particular case, a medical emergency team call. So this is the framework. This is what the world's moved to. This is where we're operating at this moment until Sepsis 4, which will undoubtedly come out in 5, 10, or 15 years after we understand more about this. But how good is it? I mean, if you take it out of the criteria that were developed using large US databases, does it pan out? Is it real? Or is it just another American construct? Which will be dangerous. And so people now have started testing. And this is a paper that appeared in JAMA recently, where centers in France, Spain, and Belgium, and Switzerland looked at patients coming to the emergency department and tried to assess whether a quick SOFA was able to identify patients that had a greater risk of mortality that were coming into the emergency department of these centers. So the people coming to the ED, suspected infection, their overall mortality was 8%, and 3% for the QSOFA score that was negative, whereas those with a QSOFA positive 2 or higher had a much greater mortality of 24%. And in this setting, in Europe, the QSOFA appeared to perform better than SIRS, had an adequate area under the curve, and defined patients with a significantly greater risk of death. So if you are in Spain, Belgium, or France, and you see somebody with infection that you suspect has a severe infection, and you do a quick SOFA at the bedside in the emergency department, and the QSOFA is positive, you've differentiated people that have some mortality, of course, from those that have a much higher mortality. But these are the Europeans, right? And according to the Americans, they are cheese-eating surrender monkeys. And the Europeans think the Americans are lunatics, as proven by the election of their president. But what about us, the Australians, the better race, the convicts, a nation of migrants and convicts? Are we better than they are? So we decided to look at what happens at the Austin Hospital. And we used exactly the same strategy used in the American database, used by the consensus criteria of Sepsis 3. So you take patients that present to the emergency department. We got electronic vital signs at the Austin. We've had them for about 2 years. Look at their first presentation. You see if they've had blood cultures ordered for suspected infection. You see if they got antibiotics to confirm that it was suspected infection. And then you look at whether they had the QSOFA criteria in the period of 6 hours surrounding infection. This is exactly a verbatim reproduction of the strategy using the data from the University of Pittsburgh Medical Center. And then you look at whether they were QSOFA positive or whether they're QSOFA negative, and then you go and check whether they lived or died. So we just finished doing that. There were 165,000 presentations in 30 months with the emergency department, and 9,000 of them had suspected infection, and 1,560 of them were QSOFA positive. But the mortality of QSOFA positive patients was indeed twice the mortality of QSOFA negative patients. And the mortality and ICU stay of these patients was indeed 3 times that of the QSOFA negative patients. But their mortality was 2.2%. So there are 2 possible explanations. Either the doctors and the nurses at the Austin Hospital are fantastic, which I can tell you is not true, because I'm one of them, so I know it's not true. Or we belong to a hardier species, which is invulnerable, and through generations of convicts has created a superhuman group of people. Or there are problems with databases and electronic information, which is the most likely explanation at all levels. So even after you create these things, it's not easy to clearly understand what is exactly going on. So let me conclude. There is a new consensus definition of sepsis. In every patient presented to the ED or being seen by the emergency department, by the medical emergency team, you must consider it. The screening system does exist. It can be done at the bedside. You've got to do a lactate. You've got to check for QSOFA. You've got to consider organ dysfunction. You've got to exclude organ dysfunction. And let me finish by saying that today in the world, the mortality of sepsis is, however you define it, at the very least is 10%. The mortality from myocardial infarction is 8.1% in Australia and New Zealand at the moment. But there is an infinite, ginormous, mega-galactic, super-duper structure to deal with ST segment elevation myocardial infarction, but there ain't none for sepsis. It's time the system should change, and I hope you will advocate for such changes. Thank you very much.